experts. Actually, I know some of you are experts, are more expert than I am. But it's still really helpful to make sure that everyone in the room knows all the basics. I want to start with just some genetics and talk about that, and then I'm going to talk about the clinical features and a lot of things about the clinical features, not only the symptoms, the unusual symptoms, but what the course is and what causes them. So DNA basics, this is the anatomy of DNA. So DNA is the code for genes, it's like the blueprint, right? And the code makes a protein. And proteins are essentially what do all the work in all the cells, right? Proteins do all the work. And so the code is made up of 4 nucleotides. I like to think of these as, alphabet, but it's TAGC. We don't need to necessarily know the names of that, but it sounds really simple, but that's what the alphabet is. And an example of a code, then, what the alphabet is just these 4 letters, but what appears to be they're not random, but that's what you'll see. Something like this is an example of a genetic code. 3 nucleotides make up an amino acid. And the one you might recognize is CAG, which is glutamine. And you think about that as letters, and then words, so the words would be the amino acids, and then you string those words together and you get a protein. So strings of amino acids make up a protein. And then the gene is called Huntington, and remember, if you see that, the TIN makes it look like, what? That's a typo. No, it's not a typo. The gene and the protein is Huntington. And essentially the code for that is HTT. Every circle is an amino acid, and the whole thing is a protein. And frequently, there are repeats. And in the Huntington gene, there are repeats. And there are repeats of this CAG repeat, the glutamine. And importantly, everybody has this gene, and everybody has repeats. It's only when the repeats are too long. So when the repeats go past 40, we call that mutant Huntington, or MHTT. And when it's greater or equal to 40, then Huntington's will develop. And the onset and diagnosis of HD, the average onset is age 40. And you'll hear me refer to that as adult onset, so AOHD. And when the diagnosis of HD is made before the age of 21, we call that JOHD. You'll hear also as JHD. I've transitioned over the years, mostly because I compare it to AOHD. I call it JOHD. The other thing is you might hear something called pediatric HD, and in particular with our European colleagues, they define this. Pediatric HD means that it's juvenile onset, meaning that there's a clinical diagnosis before the age of 21. However, that person is still a child. That person is still 18 years or less. So that's what pediatric HD is. And then if you're older than that, you can have a child that's diagnosed at age 17. So they're JOHD, but they might currently now be 25, right? So it's those definitions that I think are important. So juvenile just means when they're diagnosed. Pediatric will refer to the point that they're currently still a child. So how about that repeat length and age of onset? So we know that there's a really tight relationship, and these are all averages, right? There's differences, but in general, the longer the repeat, the earlier the onset. And late onset, right? So people who have a repeat of what we call intermediate, 36 to 39, we often say that they may or may not develop Huntington's. Typically, what I like to say is if you live long enough, you might develop it, because oftentimes when you make a diagnosis late in life, like at age 80, you might have a repeat of 39. And then here's the big bucket where most people land. Most people with Huntington's land in the AOHD with a repeat between 40 and 49. This is something that's, I must say, this is an area that doesn't receive a lot of attention because it's not adult onset and it's not JOHD. It's people who get diagnosed between 21 and 30. It's early onset, right? And oftentimes their repeats are between 40 and 50. And then the clear definition of JoHD, so if the diagnosis is before 21. But we also break that down a little bit. If you have a diagnosis between, I call 13, and in general 13 is a definition of puberty. That varies quite a bit, but in general. So between 13 and 21, that would be adolescent onset. And repeats are typically between 60 and 80. And then the childhood onset. And that would be onset clinical diagnosis before the age of 13. And typically those repeats are longer.
So you're saying onset and diagnosis. So our onset, we started developing symptoms at 8, but he wasn't diagnosed until 13.
Correct, and I'm talking diagnosis. And you're absolutely right. We're going to talk about this because symptoms occur for years and years before diagnosis. And sometimes the diagnosis is late, meaning that the clinical diagnosis could have been made a couple of years before that. But there's a big difference between symptoms occurring and diagnosis. And it's because, and I think I probably have on this next slide, the diagnosis is specific to motor symptoms. And not only motor symptoms, significant motor symptoms. Okay? It can't be mild motor symptoms. It really needs to be significant. It's an important reason why that's what the clinical diagnosis is, because that really allows us to give a good prognosis of where we think the course of the disease is. And the reason for that is because there's a lot of changes year before that. But we'll discuss that a little bit more in detail. Anticipation. When HTT is passed on from a parent to a child, there's a chance it'll expand. So as an example, a CAG of 43 in a parent can expand to a child to 65. So the parent will have adult onset Huntington's, the child will have JoHD. The expansion is more likely to happen when the parent is male. Okay? Now, it's not every single time. Most JHD cases, up to 90%, have a father with HD. Remember, that's not everybody, right? There's still JoHD families where it comes from mom. But it's really important to understand the reverse of that. Not every male with Huntington's is going to have a JoHD child. Really important to understand that. It's still a very rare event. It's very rare. But in general, it's more likely to be male. Let's talk about these clinical features, the types of symptoms. In many ways, and it used to be thought, is JoHD is simpler? It's a different disease than adult onset? It's the same disease. It's the same disease, and we'll continue to talk about that. And it's also the same, there are important differences, but the symptoms cluster in 3 main categories: motor, cognitive, behavioral. And I just want to step back a little bit and talk about brain chemistry. And this is a little bit of a simplification, but I think it's helpful to think about it this way. So dopamine is a chemical, we call that in the brain, it's called a neurotransmitter. So neuro means brain cell. And this is a picture of one brain cell talking to another brain cell. And that's how our brain works. Little bits of electricity, and they pass chemicals together. And so one cell will release dopamine, this other cell will receive it and say, okay, I know what to do. Right? Dopamine, in general, governs movement. Much more than that, but we can think about it in movement. And this will help when Jordan talks about treatment. Too much dopamine, and you're going to have too much movement, right? Involuntary movements, right? Too much dopamine. So the medications that we use for this will drop dopamine. And then the opposite is if you don't have enough dopamine, you don't have enough movement, right? So and the medications in the brain are working directly on that neurotransmitter. So in the motor symptoms, we call this too much kinesis, right? Kinesis means movement. So hyperkinesis means too much dopamine and it's involuntary movements. And that can be chorea, but it can also be tics, right? Tics can be vocal, blinking, right? It's too much movement and chorea. And then hypo, not enough, kinesis, hypokinesis. And that's like Parkinson-like symptoms. So it's slow, stiff, shuffling, can be a tremor, right? And that can manifest not only, but also in speech, right? Slow, stiff, right? When you need to coordinate all of the movements in your mouth to speak, it can be really difficult. And JoHD has prominently, in general, hypokinesis. Really important to understand that they can have both, right? They can have both, but oftentimes by the time the diagnosis happens, most of the motor symptoms are what we call Parkinsonian or hypokinesis. So thinking skills, that we call that cognitive, so cognition just means thinking. And everything from what we call general intelligence, so that's IQ, to specific functions, memory, attention, language. It doesn't really hit one specific area. It's very general changes in thinking skills. But when we think about cognitive changes in JoHD, it depends on when the diagnosis is. Because if things start early enough, like in childhood, like before the age of 10, what you'll see is maybe a failure of things to develop, right? If your child is affected young enough, maybe they're not going to develop those cognitive skills. But oftentimes what is a loss of skills, right? That they developed, they attain some skills, and then they lose skills. And you'll see academic changes, you'll see changes in the way they think and behave. And then like adult onset, the thinking skills often progress over time. So things change over time. So behavior and psychiatric, it can be divided into two main categories. We call it externalizing behaviors. These are behaviors that other people can see. So it's hyperactivity, it's inattention, opposition, not wanting to follow the rules, talking back, and aggression. Internalizing behaviors are what people feel inside, right? Sad or depressed, anxious, obsessional. Sometimes when you look at someone, you may interpret them, but really the internalizing symptoms are something you have to ask the person, are you feeling sad? Because sometimes it might look like someone's sad, but they're not really sad. You need to ask them. But the internalizing behaviors are those sad, depressed, anxious. And in general, for both adult onset and JoHD, the externalizing symptoms are the more common. That doesn't mean to say that things like anxiety and depression don't happen. They can, for certain. But oftentimes the externalizing are more common. ADHD is a really common diagnosis, especially early in the course of the disease. And aggression may come on really quickly, and it may be what I call a hair trigger, almost like seizures. Comes on 0 to 60, anger, aggression, and then it goes off. And those are really difficult to deal with because sometimes it's hard to know what those triggers might be. I'm just going to mention this very briefly because Dr. Lambert is going to talk all about this, but seizures are certainly far more common. It's not like they're completely unheard of in adult onset, but for the most part, this is a symptom that's specific to JoHD. And the earlier the onset, the more likely. So Dr. Lambert is going to really talk about that in detail. I want to talk a little bit about these other symptoms. Once again, these are not necessarily completely unique, but you see them either more severely or more commonly in JoHD. So we did a web survey. So we connected with the community. This was really helpful for us because at Iowa, we've been doing a lot of JoHD, and I kept on seeing families talk about symptoms that I wasn't seeing in clinic in my adult patients. And so we asked the community, what are the things that you're seeing in your JoHD kids? And we came up with a list: sleep disturbance, the tics that I mentioned to you before, pain, itching, and psychosis. Once again, it's not like these things don't occur in adults, it's just less common and we assumed less severe. So we did a web survey, and we had 33 responses, which is incredible, right? But that's what happens when this community comes together. The age of diagnosis for those 33, it was a relatively young onset, right? 12 years. And then the current age, that at the time that the parent was giving the survey, they were 15. And the CAG repeat length was huge. The range, right? Of those 33 people, the range of CAG repeats was 45 to 109. And this is what we found, so I'll just walk through this. This is percentage of those 33 patients who had sleep disorder. It was 87, really common. 78% had tics. 69% had pain. 60% had itching, and 39% had headache. That really surprised us. Those were really common symptoms. And then we followed that up with a little bit more specifics. The sleep was initial, middle, and terminal. And what that means is initial insomnia is when you can't fall asleep. Middle insomnia is you fall asleep, then you wake up. Terminal insomnia is when you fall asleep, but you wake up too early. So the sleep disturbance was all over the map. And it was also sometimes 10% had night terrors. And 50% of those respondents who said that there was sleep disturbance said this is not a minor thing. This was severe. It was severe sleep disturbance. So it was something that was really eye-opening. Tics were really common, especially early in the course. Early in the course. Blinking, so that's called blepharospasm. But and once again, blinking is normal. But when it's excessive, sniffing, right? So those were the most common. Pain in the legs were its most common site. 20% called this severe. We don't quite know exactly what that pain is related to. We think it's probably musculoskeletal, right? We talked about the stiffness, and that may be so, because sometimes things like muscle relaxers can help with that pain, but it's real common to have that pain. Itching, this was something that I'm really familiar with now, but when we started this, it was really a surprise to me. And it's really important that it's not associated with the rash. It's not something that you can see on the skin, oh, that itches. It's a sensation that comes from your brain that makes you want to itch. Right? So it's a sensation. And it's not unlike pain, right? We call it neuropathic pain, when your brain is telling you that you have pain, and your brain is telling you that you have a sensation and it feels like an itch. 40% called this severe. This was the only symptom that was related to CAG repeat. The longer the repeat, the more likely you were going to have itching. But it's really something that's pretty unique to JoHD. And we just think it's a change in pain sensation. And then psychosis. As a psychiatrist, and before I did Huntington's disease, I did schizophrenia, so I'm really familiar with psychosis. But this is something that can happen much more commonly in the JoHD community than the adult onset. It can happen with adult onset for sure, more commonly. Visual hallucinations were common, but also hallucinations and delusions. Delusions are just fixed false beliefs. So the idea that someone's trying to harm me, someone's trying to poison me, someone's trying to, the FBI is after me, or all of those untrue beliefs.
A question on that. So are we, even before she was in, I can't blame the medicine, because this was happening before any medicine was given. But what triggers it? She thinks she sees like a whole boat right there next to her, or she looks outside. I think it's also part of like reflection, but she's nonverbal, so she can't express herself. What do we think it's just somewhere in the brain that's...
It is. In the same way that the brain is sending abnormal signals about an itch, it's sending abnormal signals about hearing, sensing, smelling. And it's absolutely in the brain. Auditory hallucinations, right? You're hearing my voice now, it's going to a specific part of your brain, and your brain is saying you're hearing me talk.
Yeah.
And then what happens when there's a brain malfunction is that piece of the brain then signals, even though there's nothing coming from outside. It's that piece of the brain malfunctioning.
Yes.
And getting a vision. And sometimes we call that illusions, right? Where you see something and it gets twisted into something else.
Like sometimes you'll believe that bugs are crawling.
And that's a somatic delusion, right? So that's a feeling. And so these are all the brain. And it's not imaginary, right? That's the whole thing. It's absolutely, it's just as real.
Yeah.
So when you hear an auditory hallucination, it's just as real as what you're hearing right now. Your brain is perceiving a sound. And when your brain misfires and you have an auditory hallucination, it's the same exact place in your brain. It's the same exact experience. There's just no external
And there's
stimulus.
medicine for for like.
There's medicine for it. Antipsychotics, we use them all the time in Huntington's for other things.
Yeah.
We use them to quell movement, we use them for sleep, we use them for behavior. For psychosis in Huntington's, they don't work as well as they do in schizophrenia, but they do work. And that's what we would prescribe as the antipsychotics. Guess what they do? They drop dopamine. And so it's, like I said, it's a little simplistic, but it's absolutely true.
Yeah.
All of the medications for psychosis, I know there's a brand new one these days, but I don't know if you've heard about it, but all of the medications that we've had for decades that treat psychosis, hallucinations, we're back to that too much dopamine as triggering for most of these symptoms.
And then I just also want to say another, I don't know, I think a lot of us moms also talk about this, or little ones, hypersexuality. Like
Yes.
with the touching.
Yes.
And my girls, Chloe did it a lot, you know, I've touched her naked.
Yes.
And
I should add that. I should absolutely add that, especially because
I don't think we talk about it enough.
it is.
And like when we talk to our doctors, it's, well, at a standstill on what really to do.
It is. It's really hard. And I think the most important thing is because it needs to be talked about. Oh, we should talk about that.
Yes.
Because it's not embarrassing. It's normal. Sexuality is normal. But like other things, when it's abnormal, it's a symptom.
Yeah.
Right? And sometimes it's hard to change that. But in the same way that you would target aggressive behavior or sad behavior or anxious behavior, you can try to target hypersexuality medications as well, right?
Yeah, it's hard to, my girls they're little, so it's not hard, they don't know any better.
They don't.
They just know it feels good.
Exactly.
So that's why,
Yeah, it's a little bit of disinhibition, right?
So
It's kind of the same
hard
thing.
to-
I'm gonna run naked, you know? No
It's
issue.
not socially accepted.
Yeah, totally accepted. And your children were younger, but then the teenagers,
Yes.
right?
Oh, yeah.
Oh,
yeah.
that really,
I'm here
really.
to tell you.
And
Oh, yeah.
that can be conflated too with just normal puberty, right? Normal puberty is hypersexuality. And so you have to then figure out what's normal, what's abnormal. And then the piece you start coming into is when it's normal, but it's difficult. So they want to be normal. They want to have a relationship. They want to have sex. But it's not the right situation, right? That relationships for young adults can be dangerous, they can be taken advantage of. All of these discussions. You're absolutely right that I need to put that up front and center in symptoms because it's a conversation that sometimes is difficult to have, but should not be. It should not be. The one thing that I was really appreciative of being trained as a clinician is when I had kids, I could talk about sex very clinically. As a doctor, masturbation is and I was like, I'm just going to talk to them like I do a patient. But it's hard, right? It's socially taboo. It should not be. And it needs to be really discussed. Rosalie, you have your hand up.
In the other room, you were talking about metformin and being help for behaviors. Metformin puts the libido down so hard in a lot of people that take it. Does that help with the behaviors then in the end?
Yeah, that's a great question because sometimes, so for instance, it's not at all uncommon for our psychiatric medications to have sexual side effects. What we call the SSRIs, that's a serotonin, most of the antidepressants, Celexa, citalopram, Zoloft, Prozac, all of those they often cause sexual dysfunction, which would be like delayed orgasm. But they can also drop libido. So it can drop interest in sex. Same thing with some of the antipsychotics. So that's a side effect of those medications. So sometimes that can be used to decrease that. It depends on how difficult the sexual symptoms are, if they're really resulting in dangerous behaviors, right? So maybe trying to be aggressive with sex. So a young man who's trying to be aggressive with sex with young women, that would be something that you would want to consider. But we typically don't target trying to drop sexual libido with medications. Does that answer?
Yeah, I was just something that when you talk about metformin, I thought of it, that, oh, that is a side effect of metformin.
I didn't realize that was a common side effect, but I'm looking at my pharmacist.
Yeah, it's not as common, like Nick said, it's very common and with some of the SSRIs. But again, I would echo everything Peg said, where how sexual dysfunction is defined in the setting of SSRIs and other psychiatric medications is very different. Some people, it's very difficult to predict. So,
We don't know which side effect you're gonna get.
exactly. So in the setting of this conversation, you may, sexual dysfunction is reported as sexual dysfunction. That can include the delay of orgasm, but it may not decrease libido. Some people would have significantly decreased libido. The same drug would do the same thing in different people, so it's very difficult to say, let's try this medication to help with your depression, and maybe we will be able to. You could see a world where somebody who is having hypersexuality but has delayed orgasm, it could actually lead to more problems where they are frustrated at the fact that they are still hypersexual, but they're not able to achieve orgasm and things like that. It's something I completely agree that it's a really interesting thought, but it could, with every medication, every treatment decision, there could be unintended consequences.
And I think for a lot of the JoHD population, it's impulsivity. It's not as much hypersexuality, it's disinhibition. It's disinhibition, just like you said, this feels good, why wouldn't I want to do that?
Yeah, I think my concern with my girls is that, or how do you really do it? She does it a lot now, but Chloe was like sticking things, so that's when I would get scared.
Yeah.
Because I have to be careful
Yeah.
what she's trying to stick.
Yeah.
And I'm like, what are you
Yeah.
clean? But I'm sure the desires as they get older, I'm sure it's hard for the kids because they have desires. Everyone has
It is.
desires.
Everyone has desires, like I said, and it's absolutely normal. Hunger and thirst
Yeah.
and sleepiness is sexuality. It's
Yes.
the drive. So what causes symptoms? This is really overly simplistic, but it's just important for me because we talk about it all the time, and it's just this area of the brain, right? So it's the striatum, and this is what's called a glass brain because you can see through it because the striatum is in the middle of the brain. So it's this red section in the middle of the brain. We know a lot about this, and we know a lot about it because there's been hundreds, now thousands of subjects who've had MRI scans from early in the course of disease through the course of disease. So we know when this brain piece changes and when the volume gets lower, and by the way, how does the volume get lower? It's because brain cells are dying, right? That's called neurodegeneration, so brain cell degeneration. When brain cells get sick, then they die, and that's what leads to a decreased volume. So you see this volume get smaller and smaller. Once it hits a certain volume, that's when the motor symptoms start. But remember, there's symptoms that happen way before that, but we know that there's a critical value in which you will get significant motor symptoms. And the smaller the striatum, the worse the symptoms. I mean, we just know this is the progression of the disease. It's not like the rest of the brain isn't involved. Of course it is, right? But this is the region that we know gets affected first and most significantly. But the brain works by connections and circuits, and so it's connected to all other parts of the brain. So the course of symptoms is really important in JoHD. So the striatum is losing volume for years before symptoms happen. And then, while it's happening, you'll get cognitive and behavior before motor, right? Often the first symptoms are cognitive behavioral. It's slow change. Sometimes it's difficult to know if it's due to HD or something else. And the definition is that we talked about this. Disease onset is significant motor. And we'll talk about why we don't define disease onset by behavioral, because it can be tricky.
And Trent didn't have behavioral. He has never had a behavioral change.
Exactly. So
His onset was chorea.
Yeah.
Or was movement.
Yeah.
And we, in the third grade, we had little girls say, is Trent still tripping over air?
Yeah.
Yeah, absolutely.
Yeah.
And so, and even when I first became part of the moms group, it baffled even the moms. They're like, chorea is not a JHD symptom, but yes, here we are.
It is. It is. And
Yeah.
it can be a combination. And that's an excellent point in the context that not everyone has behavior. And so you can't use behavior as we could. But guess what? Everyone will have motor symptoms. Everyone will have, by definition, everyone's going to have motor symptoms.
Can I comment? So I was going to say also behavioral is some of those behaviors are also typical of that age.
Yeah.
So not only may it be slow to come on, but you're like, oh, that teenagers are that way. They have poor judgment and they're impulsive and they're this. And so, yeah, it makes it even harder to discern.
It is. Or this is ADHD. Guess what? It is ADHD.
Yeah.
Right? You know? And so it gets really circular. And so hanging the diagnosis on behavior can be really tricky, even though it's hard, right? And we'll talk about it. So I'm just going to, so they're not here, but I've gotten permission to talk about this subject. So this was a subject that came into our study. And I just want to orient you here. So this is striatal volume. So that's the volume of that piece of brain I told you was so important. So higher volume means more striatum. And all the blue points are children who do not inherit the genes. So these are all normal, healthy, they're actually normal, healthy girls, because this subject was a girl. And at the bottom here is age, from 6 to 12. So this is what happens over time, normal, healthy. You can see that it decreases a little bit, that's normal, but it doesn't decrease a lot. This was a young person who came into our study who was at a little bit less than 6 years old. And remember, it's a study of children at risk. So there was no symptoms at the time. But we followed this subject over time in our research study. We didn't know what the CAG repeat was. Family didn't know what the CAG repeat was. But when we looked back, because eventually this subject was diagnosed with JoHD, and when we looked back, we mapped her striatum. And what we could see is, when she first came to us, when she was 6, her striatum was normal. When she was 9, it was already significantly different than normal. The other thing to really important to understand is that when you get a clinical MRI scan, they just look at it. There's no volume. They don't quantify. They just look at it. Does it look normal? Because this would look normal. It's only when you measure it and you say, it's 7 cc's, right? And then when she finally got the diagnosis, but I want to show you what her progression of symptoms were. She started to have behavioral symptoms early, and some of them were aggression, really significant aggression. And sometimes it wasn't directed at people, but just, blah, tear my room apart. Sleep disturbance. And by the way, sleep disturbance can happen throughout, and especially later on, it can be impressive. Up for 48 hours. That can happen. Diagnosis of ADHD. That's something that happens really commonly, right? She was just before 9 at the time. Diagnosis of ADHD. Then, vocal tip. Hand movements. That would have been Korea. Hand movements. That were just, mom noticed that's different. That's not normal. School performance decline starting around 10. Clinical MRI was normal, right? So this was the time that we started to go to the neurologist to say, is this JoHD? Let's get a clinical scan, it's normal. And there were motor symptoms at the time. Mom said there was motor symptoms at the time. They weren't significant enough to say that this was JoHD. By the time she was a little bit younger than 12 is when they finally made the diagnosis. And it was both, right? Chorea, but it was also now the hypokinesis, right? So that's the important part of this, is that this is a long journey. The brain is changing from many years before. There's manifesting symptoms, but they're not necessarily symptoms that are completely specific to Huntington's until you get to the significant motor ones. Can we do better with diagnosis? And we'll talk about that. So the diagnostic challenge, it's a long time between symptoms and diagnosis. The most common presenting symptom is behavior, not always. And it's common in early diagnosis, right? For childhood onset, sometimes the presenting symptom is more often motor. So oftentimes for early onset diagnosis at 5, 6, 7, it's a little bit more commonly that it is motor symptomatology. But why can't the diagnosis be made and a genetic test run if there are behavior problems? You know that they're at risk for Huntington's. They have a diagnosis of ADHD. Why can't we just pull the trigger and get a genetic test? The reason is because behavior problems are not specific to HD. They're just not. And I want to walk through a scenario and why we don't do this. So why is the genetic testing based on a non-specific symptoms? The symptom may not be related. ADHD is common, right? Let's just say we had a child who was at risk for Huntington's. They got the diagnosis of ADHD. We said, let's just go ahead and test for HD. And their CDG repeat was 43. They don't have any motor symptoms. They just have ADHD. They might be having some behavior problems. This means in general, because they don't have any motor symptoms. Now you've just pre-symptomatically tested a young child. That young child is not going to get sick with Huntington's until they're about 45 years of age. Now they're saddled with that psychological information of knowing at a young age that they're going to develop Huntington's. And because they're a child, they weren't necessarily of the decision to get that diagnosis, that their parents did that, right? So this is the scenario, and by the way, I've seen this happen. And when it happens, it's tragic, because where I've seen it is young people, so teenagers, who convince their local doc to run the CAG repeat when there's no motor signs, and now they think, I'm dying. No, I mean, you have decades of quality life ahead of you before this becomes significant. So it can be really problematic. So it's one of the reasons why that we don't test based on non-specific behavioral stuff. We really need to wait for the significant motor symptoms before we know. I'll also tell you, this is you guys are the experts here. I've had some moms tell me, I'm not sure I would have wanted to know before then anyway. Why do I want to know decades before? But is there something we can do? But there's others that would tell me, I want to know right now. I need to know. I have to know. I have to know now so I can prepare. But like I said, it's very individualistic. I had families tell me the exact opposite. I know there's something wrong, I can deal with it, but I don't want yet to know that this is JoHD until I have to. So it's very individualistic. But in order to prevent this situation from happening, we have to be really clear about when to do the genetic testing. Okay, just a couple more concepts. Striatal volume in JoHD is much faster. So the whole disease progresses much faster than AOHD. So this is just, on this axis, it's striatal volume and how much it changes over time. So this is normal healthy control. And this is actually years, how many years you're in the study. So you started the study here, and then you got a brain scan here, and you got a brain scan here. And you can see that JoHD is very fast progressing, but I want you to focus here. This is compared to normal healthy controls. This is compared to adult onset. So in adult onset, absolutely the striatum decreases over time. We know that's the disease, right? But look how much faster than adult onset does JoHD. I'm not telling you guys anything. You guys know this. You see the progression is much faster in JoHD. And it's one of the reasons why we see the JoHD present with hypokinesis. So I'm going to walk you through this graph. So this is just age on the bottom from 0 to 80. It's cradle to grave, 0 to 80. And green is hyperkinesis, which is excess movement. Red is hypokinesis. And with adult onset, what you see here is that you have a very long stage of pre-symptomatic, then you have the hyperkinesis stage, and then you have the hypokinesis stage. Really important that all patients with Huntington's eventually go through a hypokinesis stage. For many patients, it's very late, right? Early onset, you're going to have that same, it's the same disease. You're going to have pre-symptomatic hyperkinesis and hypokinesis. But now the disease is just shorter, right? So you're going to have a time of diagnosis around age 28, and you're solidly in hyperkinesis. But once you start getting into JoHD, remember, same disease progression, pre-symptomatic, hyperkinetic, hypokinetic. Now you have someone who's diagnosed at 18, and they're just about ready to enter their hypokinesis phase. And by the way, like I said, it's not like it's a shift. That chorea is still happening, right? There's when they have both symptoms. And then with childhood onset, by the time we make the diagnosis, they're already in the hypokinetic phase, right? They're already burned past hyperkinesis. And so in JoHD, the hyperkinetic phase may be very hard to diagnose. What is ADHD, right? That's hyperactivity. Is that the hyperkinetic phase of JoHD? It could be. And we just see that it's the same progression of symptoms, it's just that it's so much quicker, and by the time we make the diagnosis in JoHD, they're already in the hypokinetic phase.
Is the progression commonly, is it directly correlated to the sternal volume change?
It is all of these symptoms, that the lower the volume, the worse the symptoms. And for the most part, that's everything. We connect it to the motor symptoms, but all the other symptoms are the same thing too. Now, having said that, behavior can come and go. So sometimes that gets better, sometimes it gets worse, sometimes there's new things that come on. The motor symptoms will always progress, never necessarily the new ones will come on. And the thinking skills will always, in general, progress. And that's another reason why behavior. I'm a psychiatrist. When I started in the HD community, I'm like, I'm going to make sure we diagnose based on behavior. I was wrong. Really wrong. Didn't take me long to figure out, oh, that's a bad idea. Because it's variable. Not everyone has it. It can change over the course. And the things that we know that are solid in terms of here's where they start and they get worse over time are the thinking and motor skills.
Why can't you diagnose by MRI?
By MRI? That's a great question. I've made this plea before. If we go back to that case study where I saw, and for anybody, if you had a child who's at risk and you got a clinical scan and somehow they were able to measure the striatum and you got that, if you have a child at risk, what we recommend is that you see a pediatric neurologist, clinician, over time. Because they need to see change over time in order to make the diagnosis. If they had an MRI scan where we measured the striatum, and within 2 years they saw a change, they saw a drop in volume, that would help that pediatric neurologist make the diagnosis. But that's only in research. We did so clinically, they can't get the volume of the striatum from a clinical scan.
Our neurologist.
And that's because probably by the time the diagnosis was, she was already significantly into the motor phase. But when you get it earlier on, as a radiologist, it may not look really small. Eventually, it will become abnormal. Eventually, you can look at the scan and you'll say, oh, the striatum is abnormal. But early in the course of the disease, it will look normal.
Is that the horning? What they call the horning on the MRI?
Horning, yeah. Because the striatum is right up against the ventricles, so the areas of the brain that are filled with fluid. And so it's the shape of the ventricles that can change, that visually is really distinct. But the reason that the ventricles change the shape is because the striatum is decreasing volume. So when you decrease the striatum, the ventricles get bigger.
How is the striatum and the basal ganglia? You hear those?
Oh, that's a great question. They're pieces of the same thing.
Okay.
Basal ganglia is a little bit broader term that includes other structures. Striatum, for the most part, is caudate and putamen. And those are the structures, right? There's other structures in the thalamus, there's globus pallidus, and so there's anatomically, the definition of basal ganglia is broader. Striatum is just the caudate and putamen.
Okay.
But if you think of you're thinking of the right thing.
Okay, because I've heard it referenced when looking at his MRI.
Pretty much the same thing. Basal ganglia will include some of the other, we call them subcortical. So cortex means bark, and essentially cortex is the outer rim of your brain.
Okay.
So it's the outside. Subcortical means all the gray matter in the middle of the brain. There's a lot of little structures in there that we all like to, oh, this is this little piece, this is this little piece. And in general, the basal ganglia are subcortical structures, and like I said, it includes several different structures. Part of that is the striatum, and like I said, there's neostriatum,
You can go for days.
lots of different ways that you can anatomically parse it up. But
I was just wondering how far apart those two
no,
are,
they're
but
very
not.
similar.
Okay,
Yeah.
thank you, thank you.
Can your CAG change at any time to make it progress faster?
Great question. In general, we get CAG repeat from the blood cells in your, right, so we can get it from a blood test, leukocytes and white blood cells. In general, when we test that over time, it stays about the same. We know that's way different in the brain. In the brain, when we test it over time, and it is hard to do, right? You can't get brain tissue, but we do this on postmortem brains. In the striatum, the CAG repeat is way higher, and we know that increases over time. So you may start out with a CAG repeat in your striatum of 45, eventually it becomes 100, 200, 300. That's, yes.
So that's why I know, I'm just gonna throw my own. Chloe and Ari, like, it just happened so fast with their diagnosis. It was just, I was saying end things at the beginning, and it was just all out of whack, not in the order specifically what usually the kids go through. It just happened so fast from 1 month to the next. Just major decline. So the numbers can increase in the brain.
They can increase in the brain. There's a lot of work on that. It's called somatic instability. You've probably heard that term. People are very interested in, is this what drives the disease? I'll say that there's a lot of uncertainty about that, but there's a lot of excitement about it because that's what we target with medications. There's still a lot of uncertainty about it.
So technically, we just have a gist of their CAG number. We don't really know for sure.
Well, we certainly know what it is in their blood.
Yeah.
We can test that. We can test that really solidly. And we know in general that in blood, it's stable over time. But guess what? You know what? If we look in the liver, it's not stable. In liver cells, your repeat goes high too. But your liver doesn't die in HD. So is this somatic instability really what's the disease? We don't know.
Yeah.
We don't know. It seems to be, we know that in the striatum, it seems to be especially big. That somatic instability in the striatum is gargantuan. So it seems to be that's related, but like I said, we don't know about it.